This lesson will continue part 2 of the high-risk newborn. Hyperbilirubinemia is in the first 24 hours of life is most often the result of hemolytic diseases of the newborn. Major causes of increased erythrocyte destruction are isoimmunization and ABO incompatibility. So let's review blood incompatibility, also known as isoimmunization. The membranes of human blood cells contain a variety of antigens, also known as agglutinogens, substances capable of producing an immune response if recognized by the body as foreign. Okay, so Rh incompatibility. Only Rh positive offspring of Rh negative mother are at risk. If the fetus is Rh positive and the mother is Rh negative, mother forms antibodies against the fetal blood cells. Okay, ABO incompatibility. It occurs if fetal blood type is A, B, or AB and the maternal type is O. Incompatibility arises because naturally occurring anti-A and anti-B antibodies are transferred across the placenta to the fetus. Exchange transfusions are required occasionally. So for prevention, there may be administration of Rh immunoglobulin, human gamma globulin, also known as RhoGAM. Then we have intrauterine transfusions. This consists of infusing blood into the umbilical vein of the fetus for infants and mothers already sensitized. Then we have exchange transfusion, is when the infant's blood is removed in small amounts and replaced with compatible blood. The standard mode of therapy for treatment of severe hyperbilirubinemia and high drops is caused by Rh incompatibility. Treatment of jaundice is phototherapy and or exchange transfusion depending on the severity of it. The severity of maternal diabetes affects infant survival. It is determined by the duration of the disease before pregnancy, age of onset, extent of vascular complications, and abnormalities of the current pregnancy, such as pyelonephritis, diabetic ketoacidosis, pregnancy-induced hypertension, and or noncompliance. They tend to have characteristic appearance. They could also experience macrosomia, increased risk for birth injuries, and an increase in congenital anomalies. Nursing care management includes adequate thermal regulation, carbohydrate feedings as appropriate, and checking serum glucose levels. Remember, the high-risk neonate is a newborn regardless of gestational age or birth weight and has a greater chance of morbidity and mortality. This encompasses the period from viability, 23 weeks gestation, to 28 days after birth. The high-risk newborn will definitely need a thorough assessment, potential for respiratory support, and definitely thermal regulation, such as thermal stability, a neutral thermal environment, potential for incubator, and of course to have the skin-to-skin contact, also known as kangaroo care. The image to the left is exogenous surfactant administration via the endotracheal tube. It's used as a preventative or prophylactic treatment of respiratory distress syndrome. The image to the right, the infant is being resuscitated at birth. Note the presence of meconium on the abdomen and the umbilical cord. Continuing with the care of the high-risk newborn and family, you want to make sure there is protection from infection. Standard precautions will help protect from infection. It's an integral part of all newborn care, but preterm and sick neonates are particularly susceptible. Hand washing is the foundation of a preventative program. Hydration is also key. High-risk infants often receive supplemental parenteral fluids to supply additional calories, electrolytes, and water. And it is important for nutrition. Optimum nutrition is critical in the management of low birth weight and preterm infants. but there are difficulties in providing for their nutritional needs. Breastfeeding provides optimal nutrients. Enteral feedings, along with the mother's milk, can be a good resource. Then we have gavage feeding, and then we have nipple feeding. Okay, we're going to continue discussing the care of the high-risk newborn in the family. Well, let's discuss energy conservation. An infant who is not required to expend excess energy to breathe, eat, or alter body temperature can use this energy for growth and development. Skin care. The high-risk infant can have skin that has increased sensitivity and fragility. It can become easily excoriated, denuded, and the skin is thinner. Looking at developmental outcomes, infants respond to a great variety of stimuli, and the atmosphere and activities of the NICU are overstimulating. Consequently, infants in NICUs are subjected to inappropriate stimulation that can actually be harmful. For example, the noise level that results from monitoring equipment, alarms, and general unit activity has been correlated with the incidence of intracranial hemorrhage. Personnel should reduce noise generating activities. Approach behaviors. When infants have reached sufficient developmental organization and stability, interventions are designed and implemented to support their growing abilities. Approach behaviors that are supported and enhanced include tongue extension, hand clasp, hand-to-mouth movements, sucking, looking, and cooing. Signs of stress or fatigue that signal the infant's need for timeout are described in Table 25-10, page 704 of your textbook. Review this table. Family support and involvement. Parents need to be informed of their infant's progress and reassured that he or she is receiving proper care. The parents need to have some contact with the infant. We want to be sure that we're facilitating parent-infant relationships. They may have anticipatory grief. Parents may be reluctant to establish a relationship with their infant, and they prepare themselves for the infant's death while continuing to hope for recovery. Family-centered care of high-risk newborns includes encouraging and facilitating the parental involvement rather than isolating parents from their infant and the associated care. Let's talk about discharge planning and home care. Parents become apprehensive and excited at the same time as the time for discharge approaches. Okay, so now we're going to summarize all the key points we just reviewed. Preterm infant. These are infants born between 37 weeks gestation. They have the immaturity of most organ systems. The actual cause is unknown. They have distinct characteristics such as being small, scrawny, and a large head, and they have translucent skin, and they may also have lanugo. A late preterm infant is born between 34 and 36 weeks of gestation. They're referred to as a late preterm rather than near term. They're higher risk for problems that are related to thermoregulation, hypoglycemia, hyperbilirubinemia, sepsis, and or respiratory function. Some of the complications of preterm birth are respiratory distress syndrome, and they're going to need oxygen therapy. So the respiratory distress syndrome could be hyaline membrane disease due to surfactant, due to the absence of the alveolar stability, or the prolonged hypoxemia. We can do oxygen therapy through endotracheal tube or continuous positive airway pressure. Some associated complications can be pneumothorax, a bronchopulmonary dysplasia, chronic lung disease, retinopathy of the prematurity, inhaled nitrous oxide, intracorporeal membrane oxygenation, and necrotizing enterocolitis. Post-term infant, this is gestation that extends beyond the 42 weeks. Accounts for about 3.5% to 15% of pregnancies. The cause of delayed labor is unknown. There could be a placental dysfunction. They'll have significant increase in fetal and neonatal mortality. They can have current fetal distress, and they can have an increased risk for birth injuries. Okay, we're going to talk about newborn screening. Um, they could check for inborn errors of metabolism, such as congenital hypothyroidism, phenylketonuria, use of a Guthrie paper to test that. Then we had the galactosemia, and then, of course, genetic evaluation and counseling if needed. Briefly overview the congenital anomalies. Most common major congenital anomalies are cleft lip and palate, esophageal atresia, tracheoesophageal fistula, an omphalocele, a gastroschisis, a congenital cardiac defects, congenital diaphragmatic hernia, neural tube defects, myelomeningocele, a developmental dysplasia of the hip, clubfoot, hypospadias, disorders of sexual development, and or bladder exstrophy. This concludes the lessons of high-risk newborn. If you have any questions related to the lesson content, contact the instructor.